Good afternoon. I hope everyone is doing well. Today I'm going to do my article presentation. My article is on cognitive behavioral therapy for PTSD and somatization. This is an open trial out of the University of Miami. Many PTSD symptoms overlap with multiple unexplained physical symptoms such as nausea, diarrhea, vomiting, dizziness, shortness of breath, tingling sensations, and loss of the voice can be considered psychological reactivity to cues related from trauma. Data from the Canadian Community Health Survey showed that people with PTSD were more likely to have a lower quality of life, more days of disability due to mental health, and were more likely to report suicide attempts than people without PTSD. Latinos are the largest ethnic minority group in the United States at 16.3%. This is based off of the 2010 census. By 2050, this projected population will be 1/4 of the population in the United States. Yet they have less access to mental health services than white Caucasian Americans. Some of the reasons for this can be that we do not have professionals that speak Spanish that are fluent enough to communicate with Latinos that have a difficulty speaking English and prefer to speak more Spanish. And also the clients themselves sometimes hold a belief and a belief about mental health and also about the treatments for mental illness. With that being said, it has been suggested that the high rates of somatization in Latinos is associated to the stigma against emotional expression as a sign of mental illness. The current study presents a protocol to treat both PTSD and abridged somatization based on two existing treatment manuals: cognitive restructuring for PTSD and cognitive behavioral therapy for somatization disorders. The goal of this open trial study was to report preliminary evidence of the feasibility and accessibility of an adapted and integrated protocol to treat comorbid PTSD and multiple unexplained physical symptoms, and to estimate effect sizes to inform a future randomized clinical trial. The participants were recruited in South Florida from outpatient clinics at major regional hospitals, local community agencies providing services for victims of domestic violence, and through advertisements in local newspapers, local newspapers, and the ads in the papers would read something like, have you lived through a frightening or distressing experience in your life? Do you have multiple physical symptoms? And these questions would be joined together, one comma and then the other, to get people to answer in response to both questions together. Of course, they had for the participants, they had inclusion criteria, and the inclusion criteria were current diagnosis of PTSD as defined by the DSM-4, and also they had multiple unexplained physical symptoms as defined by the abridged somatization criteria. that requires at least 6 symptoms for females and 4 symptoms for males out of the 35 symptoms that are listed of somatic symptoms in the DSM-4. They needed to be there, the age was between 18 and 65. They needed to speak either English or Spanish and be self-identified as Latino. Exclusion criteria was a little bit more lengthy. Current substance dependence, no current substance dependence. Psychotic symptoms within the last month preceding baseline was an exclusion. Suicidality or homicidality requiring hospitalization within 6 months preceding baseline. Any severe cognitive impairment or history of serious organic mental disorder. Number 5, an unstable major medical condition. Number 6, a medication regimen for physical symptoms that had not been stable for at least 3 months. 7, current pregnancy or expecting to become pregnant close to baseline. Number 8, concurrent psychotherapy provided by a mental health professional at the time of recruitment. And number 9, endorsement of ongoing domestic or intimate partner violence. So those were the exclusions. So the treatment plan was 10 to 14 sessions of a CBT intervention for both PTSD and somatization delivered at a community clinic on a Southeastern University campus. The treatment was delivered in a module format. To maximize its flexibility, there were 4 total modules. The procedure was set out to be a potential participant. Potential participants were screened over the phone or in person to the inclusion or exclusion criteria. And those who screened were invited for a 3 to 5 hour assessment conducted at the university clinic or at one of the partner recruitment sites. Participants were paid $50 for the baseline assessment and $30 for the post-assessment, which was scheduled a week after the end of treatment. They had 2 measures in place for the study itself. The clinician administered PTSD scale, which is CAPS. The CAPS was used to confirm PTSD diagnosis and was administered at pre and post treatment. This measure assessed frequency and symptoms and severity in the past month. Then they used a clinician global impression of change scale. A clinician's judgment of the severity of somatization based on the symptoms endorsed and the impairment they cause. At baseline, the patient is rated for global severity. At post-assessment, the patient is rated for improvement. This is done by an independent clinician who did not treat the participant. Severity was rated on a 7-point Likert type scale, and this same scale was used at both assessments. So the results of the study was there were 295 participants that were initially screened. 49 were invited to the assessment for screening. 40 of those had a baseline assessment for eligibility, and from that, 11 were initiated on to therapy. Of those 11, 1 left at session 5 because it was determined that she was receiving psychotherapy on an individual basis outside of this study, and she was asked to terminate the study. 2 did not return for the post-assessment. So they completed the whole study, the whole treatment plan, but then didn't come back for the post-assessment, so they counted them as dropouts. So in the end, from the 11, they had 11 participants that actually completed. So from those 8 participants that completed, the mean age was 46.7 years. There were 7 females and 1 male, all self-identified as Latino, which should be expected because that was one of the inclusion criteria. 3 were employed. All reported an annual income less than $25,000. When it comes to trauma causing most impairment, 5 reported physical assault, 4 other life-threatening events, 3 sexual assault, 1 reported a motor vehicle accident, and 1 reported a job accident. Of the somatic symptoms, so what was actually causing in their body, what symptoms did they have? 6 reported numbness or loss of touch, 5 reported headaches, 5 joint pain, and 5 reported back pain. The participants reported that the intervention was satisfactory as measured by their responses to an item question that they had to answer as a self-report, which is the procedures used in my therapy are well suited to my needs. From this question, out of that report, the total score was 110. Of the 8 participants, 4 or 50% of them did not meet criteria for PTSD diagnosis at the end of treatment. The researchers end with saying, "We do not know if the gains after treatment will continue over time, and as such, longer-term follow-up assessments are needed." I agree with that 100%. My critique of this article or this study was that it was a very small study, only 8 participants. At the end of it, they also state that they are currently conducting a randomized clinical trial comparing participants assigned to the current treatment with a treatment as usual condition. The very beginning of the article states, "No treatment to date has been developed," so I really don't know what treatment as usual is, because I don't know what they're talking about there. Again, it was only the population that they looked at here is only Latinos. In the results, they lost 4 participants. I'm one of those people that always does the math when I'm looking at somebody's results in a research study. I always double check their numbers. I look to see if it makes sense. And they lost 4 people, and they never accounted for them and never said what happened to them. So somewhere they lost 4 people. It's heavily biased. 7 women and 1 gentleman, and I guess that's just the way it happened, but it does sway that way. They did not address day-to-day stressors such as immigration or issues of family members' lack of basic resources due to employment, including living situations and integrational conflicts. So I think those are things that they could have addressed. My question to you is, do you think that any absolute conclusions can be made when a researcher uses such a small sample size? There was some stuff in here. I want to throw this in here real quick before I run out of time. This article does cover kind of why they use Latinos, and some have some good points behind why they go at it the way they do that I kind of left out because I'm low on time. So I don't think they're just misrepresenting the numbers, by no means. I think they had some good reasons why they used this ethnic group and why they went at it the way they did. It just happened to give them a really small population to work with. So look forward to your remarks. Thanks a lot.